My name is Michael Giuliano. I'm a clinical neonatologist by training. I've been actually in the Hackensack system for the past 15 years as the director of neonatology at Hackensack. But I was part of the original group that started the dean's cabinet back in, I guess, 2016 now. Wow, it's amazing how many years have gone by already, and that we're already 3 years in, and we actually have a graduation date for our first class on June 3rd of 2021. It boggles my mind that it's gone that quickly. But I've been working now full-time at the School of Medicine for approximately the past year and a half, with a focus on faculty, resident, and student development. And actually been at JFK a fair amount lately, working mostly with the house staff, but obviously as we move forward, looking forward to working more and more with faculty. And indeed, I believe JFK is also adding their PEDS department in the winter. So we'll be having more students around, and hopefully our staff will be around as well. I thought before we would go anywhere, we just start by just introducing the team so everyone has a face to the names, especially around the issue that we've just discussed. Go ahead, you can go to the next slide, thanks. And just a quick outline so that everyone has a sense of where we'll be today. So Dr. Sally Schwab is not with us tonight. Actually, she's celebrating with her daughter. So we're gonna let her get off the hook this time, but she'll be back, I'm sure. Obviously, there's me back on my clinical day. Elizabeth Colts is the Director of Instructional and Curricular Design, and she'll be very involved in some of the workshops that we do, and I'm sure you'll run into them. Of the people here, the most important person that you want to know is, and not that you don't want to know everyone, but Joe Martinelli is actually the person that Dr. Winter was just referring to that can be immense assistance in getting your application process through the School of Medicine. Make sure you write Joe's email down. Obviously, our staff is more than happy to try to help in the Office of Faculty to get your appointments through. But especially Joe has been extremely helpful and actually has been specifically assigned to assist the JFK faculty with those kinds of issues. So please make mental note. And then very soon you'll be meeting Jennifer Mansky, who'll be presenting tonight on the learning environment, and Doug Fabrizio is going to be presenting on the 1-minute learner. So you'll get to know them fairly well very quickly. Just to back up a second on the slide before, with just our agenda tonight. You know, Zoom is an environment where we found that you can't really spend an hour and a half in front of this computer. It's just not possible. Our students obviously fatigue, we all fatigue. And I thought what we would try to do is really address I think, two of the most important things that we do, and that is create a safe learning environment. Everything else we talk about is predicated on the fact that we've created an environment that is safe, that is engaging, that's bringing the students in and having them feel a part of a team. And it's so fundamental. We're going to begin with that idea. And then we're going to have a little breakout session to talk about some of the issues that can come up in creating that kind of safe environment. And then we're going to have Doug follow up with a review of the primary structural model for how we would like to organize learning in the clinical setting, the 1-minute learner model, which we have found to be incredibly effective and improve your efficiencies. You know, everyone always says, how do I see patients and take care of a student and do teaching? And actually, I think the 1-minute learner model has been shown to actually improve your efficiency and improve education. And we'll have a little bit of a breakout session after that, and certainly a little bit of time for questions. Just a small announcement. We will be recording this session so that everyone's aware that we will indeed be recording it and potentially using it on our website for future review. So I think that's important for everyone to know. And of course, if questions come up as we're discussing things, please don't hesitate to put your question in through the chat. And if the group is small enough, and hopefully it won't be so overwhelming, we would encourage you even to just unmute and to, to speak your question as well, especially if you think it's generalizable. Hopefully that's the housekeeping issues. Next slide, thanks so much. So I think most of the faculty hopefully have a sense of the overall curriculum. I'm sure that Rosa has probably discussed this with you multiple times, And the bottom line is that our phase one is quite different than most medical schools. But our phase two section in the clerkships is really fairly traditional. I think anyone would recognize this block approach to various subspecialties: internal medicine, surgery, family medicine. Peds and OB is integrated slightly, and psychiatry and neurology are integrated slightly. But for the most part, it's a pretty traditional approach. What we are doing slightly differently is we're obviously putting step one after the rotations, and we're integrating emergency medicine into each of the clerkships itself. But for the most part, it is a pretty traditional setting, although I think the models that we're proposing are far from traditional, and we'll touch on those, of course. But that's just so everyone sees. Again, this slide will make available to everyone, but I think it's really important that you recognize who the critical people are to get in touch with. And we've made a point of especially highlighting the people that are at JFK that are indeed leading the charge. We did not include, we did, the PEDS people. I'm not sure we have the names for the JFK people yet in pediatrics. Catherine Klauser is the overall director of the clerkship in PEDS. But there'll be, I presume Dr. Anand and his colleagues will be, Dr. Hauser, I believe, is going to be helping to coordinate in PEDS. And as you can see, obviously, there'll be family medicine coordinators in various sites as well. This is an important, important contact information for you if any questions come up, because indeed, if there are any issues that come up around the students, obviously, Dr. Mendoza should be the first stop for people to talk with. Next, please. So I think it's important for everyone also to recognize that this faculty development is really in the context of a much broader effort to create a common culture of learning and teaching really across the entire curriculum. You should recognize that the students are receiving an educational program entitled Settled. And indeed, we're also working with the residents in a RATTLED curriculum. And we're working with faculty in a frame curriculum. And each of these curriculum really overlap dramatically. Next. You can see that obviously the settled curriculum is helping students to actually recognize their role as not just students, but actually as teachers. It's an interesting way of sort of thinking about them. They got to get used to that idea, but they're learning slowly and steadily that they're also educators. And then of course, in the next slide, we can see the program that we've spent a lot of time at JFK working on is the RATTLE program. Actually, a particular shout out to our friends in neurology that have actually been our hosts. We've been utilizing their conference room and indeed working with the neurology house staff extensively in the development of the RATTLE program. And we're in the midst of actually developing specialty-specific programs in RATTLE for each of the programs at JFK and around the entire system. And then what we're doing tonight in the next slide is really a framed curriculum for faculty. That is, faculty as a resource, assessor, mentor, educator, and diagnostician. And as we move through these materials, you'll see that we'll be touching on many of those elements. But the bottom line is that we're really trying to create this common mission and vision about transforming medical education in a way that everyone is working together in a collaborative, safe environment, that we all have this common model of active learning and information mastery, that we're all growing, not just faculty and residents and students, but all of us are growing together in our knowledge base, and of course, always trying to push higher order thinking. And with that relatively brief introduction, by the way, this is aspirational. The integrated curriculum is actually only on paper, but we're starting to work with our interprofessional colleagues and actually hopefully we'll roll this out over time. But it's coming when we can start working with all of the other health professionals that we work with in the clinical environment to really do the best we can in terms of patient care. So with that relatively brief introduction, I'll stop right here if anyone has any questions at this point, and otherwise we'll move into and have Jennifer start. Any specific questions that have come up about the overall structure and or the processes that we just talked about? All right, very good. So without further ado, Let me introduce you to Jennifer Mansky. Jennifer is one of our faculty developers, has been working at the School of Medicine for quite a while and has been instrumental in building many of these programs. And indeed, one of her favorite subjects is creating this wonderful positive learning environment. Jen, it's all yours.
Hi, everybody. Thank you for the nice introduction. So we're going to be talking about really the connection between a safe learning environment, and learning, and how do we create that safe learning environment, and really what is the effect that it has for students. And Dr. Schwab has, she has discussed a lot about the safe learning environment. So today we're gonna, dig deep into it. And we're gonna start off, being on the next slide, we're gonna start off with this video clip. In this movie, The Paper Chase, was actually from the 1970s, and it's about a first-year student from Harvard Law School. So I want you to watch the video, and as you watch it, I want you to think about how you would feel if you were the students. Okay, so we can play the video.
Mr. Hart, will you recite the facts of Hawkins versus McGee? I do have your name right. You are Mr. Hart.
Yes, my name is Hart.
You're not speaking loud enough, Mr. Hart. Will you speak up?
Yes, my name is Hart.
Mr. Hart, you're still not speaking loud enough. Will you stand? Now that you're on your feet, Mr. Hart, maybe the class will be able to understand you. You are on your feet?
Yes, I'm on my feet.
Loudly, Mr. Hart. Fill this room with your intelligence. Now, will you give us the facts of the case?
I haven't read the case.
Class assignments for the first day are posted on the bulletin boards in Langdale and Austin halls. You must have known that.
No.
You assumed that this first class would be a lecture, an introduction to the course.
Yes, sir.
Never assume anything in my classroom. Mr. Hart, I will myself give you the facts of the case. Hawkins versus McGee is a case in contract law, the subject of our study. A boy burned his hand by touching an electric wire. A doctor who was anxious to experiment in skin grafting asked to operate on the hand, guaranteeing that he would restore it 100%. He took a piece of skin from the boy's chest and grafted it onto the unfortunate boy's hand. The operation failed to produce a healthy hand. Instead, it produced a hairy hand. A hand not only burned, but covered with dense, matted hair. Mr. Hart, what damages do you think the doctor should pay? What did the doctor promise?
There was a promise to fix the hand back to the way it was before it was burned.
And the result of the operation?
The hand was much worse than before he went to the doctor.
How should the court measure the damages? What should the doctor pay the boy?
The doctor should the doctor should pay for what he did. And he should pay for the difference between what the boy had, a burned hand, and what the doctor gave him, a burned and hairy hand.
Mr. Pruitt.
So that's what we we don't want our students doing when they're in our classrooms. And I asked, so how would you feel? Probably not pretty good at that moment. And it doesn't look like the student felt great about himself or being in that class with that teacher. So that's really what we're talking about. And under the umbrella of creating a safe learning environment is student mistreatment. And it's a very common issue that's seen in medical education. And that, of course, you saw not just in medical education, in all education. That was a law school. And it's really critical that we are able to recognize mistreatment, know who do we report it to, what signs to look for, and that we're creating a culture in which we do not accept bullying, we don't accept abuse, and these issues really need to be escalated when we see them and taken seriously and reported. Because if we don't, what happens? Then we're saying it's okay, right? And we're creating a culture that we don't want. And these issues are going to happen, they're going to come up, so we need to be aware and prepared to respond when we see them, and to prevent a small problem becoming, a bigger issue and getting worse. Because if a teacher is treating one student one way, it's very likely they're going to be treating other students in the same manner. So we really want to look out for it, because it is a big issue that's been going on for years, a long time in medical education. Okay, next. Okay, reflections. That's it. Self-reflection is very important. So I want you to think about a time when you experience personally, or you saw it from an outside perspective, you watched someone else experience mistreatment by a faculty member or a resident. And, think about, how did you feel, or how did they feel? And what was done about it? Can anyone share real quick about experience, something that comes to mind? Has anyone ever seen a student get mistreated? And physicians out there, when you were in medical school, has that ever happened? Right. I'm guessing that we've all experienced it. And how did we feel? Did we feel good about it?
When I was a medical student, I'll never forget, I used the word Lasix in front of a nephrology attending who ripped my right arm off because I had used the proprietary name instead of the generic name, as if I had murdered someone. He actually drove me into the ground, and his almost started yelling over using the term Lasix. I never forgot it, ever.
And so how did you feel?
I felt belittled. I felt embarrassed. And actually, there was a part of me in the back of my brain, I felt bad for him, because I said, what a crazy man that he's getting this riled up around something like that.
And did you do anything about it, or did you let it slide?
Oh, no.
At the time?
He was
probably a little...
he was a brilliant attending.
Right?
And I didn't argue with him. I didn't say a word about it. And actually, I have to be perfectly honest, I actually did a grand rounds at that institution a number of years ago, and he introduced me, and I made a remark. So I guess I did do something about it, but it was 40 years later.
Right? A delayed response. And that's a really great example, because when these things happen, that's exactly how students tend to feel. They feel belittled, and they're often scared and intimidated to speak up, right? They don't want a poor evaluation. They don't want to be belittled even more, right? They don't want others talking about them. So this does happen in school and in the real world, right?
It's also impressive how those experiences stick with you the rest of your life.
They really do, yeah. You remember them, and then what happens is people take it with them, and then when they get to be an attending, right, they might say, well, this was my experience in school, and this is how I'm going to treat my students now. So it's a cycle often, and we want to, break that cycle. So thank you, great example.
It made me never want to ever do that to anybody else. And I still remember his name if anyone wants the reference.
I had a similar experience with a breast surgeon, I remember. And similar to Michael, I myself also, I think I turn it around though. For me, again, it's more, I will make sure, or I'll do my best not to do that to a student ever, and to teach them again, when they teach students as residents and as attendings, to also treat everyone with respect. But I can see how it may not be the same case for everyone.
And that's what we want, right? If we have an experience that was negative, we want to learn from it and learn what not to do. And sometimes that happens. Other times it doesn't. So that's why we really need to recognize it. Wonderful. So this was a study done in 2016. This was taken from a study from family medicine study. Students were asked, what qualities do you value in your teachers? And it's in order. So the ones at the top are the ones that they most value. So they most value creating a safe learning environment, being a good team member. And it's important to note that at the bottom, the one that's least valued is having a good fund of knowledge. So students want to feel a part of something, right? They want to feel important. They want you to know your name, and having, knowing a lot of content and a lot about the subject was really something that they might have felt important, but really the least important. And to just highlight the point that education, healthcare, it's about people, and we really want to put the human factor, into all we do, and not forget about that. So, what is a safe learning environment? Right, it's gonna be a very broad topic. I don't want to. You pick a word. What do you think of when you think about a safe learning environment? What does that mean? What's one quality of a safe learning environment? What's one thing that you think has to be in a safe learning environment, or else it's not safe?
Jen, I think for a learning environment to be safe, there's got to be open communication. It's a good sign of a safe learning environment where the facilitator and then also the student, if they're able to have dialogue back and forth and share their opinions, I think that's a sign that there's a comfortable relationship. There's a good working relationship between the two individuals.
Yeah, and that reminds me of that term psychological safety, which I really love to point out. Do students feel comfortable asking questions, bringing up concerns, or do they think they're going to be made fun of, right? Thought lower about. So that's definitely important. Anyone else think of anything that's really critical?
Must say, in this day and age of COVID-19, the first thing that came to my mind was not the teaching environment, but the physical safety.
And that's certainly a part of it, especially in COVID, but not just in COVID, right? Do people feel that, their peers, right, are they comfortable around their peers, in today's world? Or we have social distancing, and we have a training session at a big room and a lot of people. We might not feel comfortable nowadays, so we do want to look out for that. Make sure we're following protocols. But a safe learning environment really sets the tone, and is really crucial. Okay, next. So, how do we create a safe learning environment? How do we have that open communication? How do we feel physically, right, safe, and psychologically safe? So we want to let students know it's okay not to know, right? Nobody knows everything, and we don't want students to think that they do know everything. They're clearly very bright, they got accepted to medical school, but it's harder to admit sometimes what you don't know than what you do know. And we want to make sure our expectations are realistic and clear, right? And sometimes we need to reset expectations and make sure they're communicated. Are we all on the same page? And then utilizing inclusive language. For example, saying good morning, everyone, rather than good morning, ladies and gentlemen. Want to pay attention to those pronouns. In this cohort, there's more than he and she. So we want to be respectful and sensitive to that, so that the students feel comfortable and being with us. And that open communication. We're not making fun of patients. I've heard the term, when people often come into the emergency room, frequent flyers, and we don't want to use terms like that, right? We don't want to put those labels on patients. And then we have the term scut work. We're going to talk more about that, but really scut work is work with no educational value. For example, asking the student, can you get my every morning I need you to get me a cup of coffee, or once a week I need you to make me an appointment to my favorite spot, right? Well, it might be good perks. That's not appropriate, and it doesn't have any educational value to the student. Next slide. So speaking about scut work, okay, it doesn't always have to be a negative thing. For example, we can make it a teaching moment. So asking a student to take a patient to radiology, right? While a student at first may perceive it as, scut work, well, why do I have to do this, right? This is mindless. It's really an opportunity for learning. It's an opportunity for the student to establish a relationship with the patient. And sometimes we need to communicate that to the students. And there are consequences to scut work. Okay, what are they? Anyone wanna add what's the consequence of scut work? Are the students gonna want to come to work every day? Are they gonna feel it's important? What they're doing? Probably not, right? So we want to make it a meaningful experience, and we want to make sure we're treating students, we're showing them, we value who they are, and the work that they do is really important. Right, next. So what are some barriers to a safe and active learning environment, right? It's not that we don't want to have that safe environment, it's what gets in our way. So, many times people don't know what you're thinking, and you have to make sure, are you communicating, appropriately? Sometimes we're a little sarcastic and say things, and students might interpret it, the wrong way. So we want to make sure we're just, being clear, and, connecting what, they're learning in the classroom to patients and what they're going to see in patient care. And, it's not just about memorizing facts, right? Everything is really interconnected. Next. Okay, and there's a lot of talk about perceived versus intended behavior. So you may not have intended, right, to insult the student, but they might perceive it like that, and vice versa. So there's a lot of misconceptions that learners are, oh well, they're just being too sensitive, or we did it, right? We went through this in medical school, so you can take it, right? That's what we all have to, like a rite of passage, right? Like in college when you join if anyone's ever joined a fraternity, right? And that rite of passage. And so we don't want to go down that path. So we really want to have an open conversation about what is student mistreatments, right? And if they feel they're being mistreated, to speak up, and that the doors are open, that they should speak up and they should report it, and to have a conversation about it so that everyone is on the same page, is really important. I think first, having a one-to-one conversation, saying, this is, what I observed. I have a concern. How can we work together to understand what's going on, and how, from a faculty point of view, saying this, and how can I support you? So those are definitely big barriers that get in our way. Next slide. And a lot of times, we have forward with feedback. Sometimes we just don't have the skills, right? We don't know how to give feedback. We don't communicate the way we should. We assume, oh, the student knows what I'm thinking, right? But they're not mind readers, okay? Oftentimes we don't know the student, all right? And everyone obviously is different. Everyone has different personalities. Some people are more sensitive than others. So really want to get to know the student as best you can, right? Sometimes time is limited, and it is constrained. So we want to be careful, because everyone really, is different and does have different sensitivities, right? We've all had different experiences in life that makes us sensitive to different things. And people have egos, right? So we don't want our egos, to get in the way. And we don't want to say, well, Dutch doesn't want to come in saying, well, I'm the attending right there, just a student. What do they know? Okay. Because we're all humans. So we want to send a positive tone of respect, and establishing that respect, and it goes both ways, teacher to students, and student to teacher. Next slide. So what really is student mistreatment? And before we go to the definition, what does student mistreatment mean to you? Anyone want to share? What's the first thing you think of with student mistreatment? What does mistreatment mean? Is it treating the student well?
He didn't learn.
Yeah. Oh, yeah.
Go ahead, Aditi.
He or she learn.
Can you repeat that?
I think the student is here because he or she is here to learn, and if they did not achieve the learning they were supposed to, then you call it mistreatment.
Okay. Okay. So you're saying that if they didn't learn what they were supposed to?
Mm-hmm.
Okay. Any other thoughts about student mistreatments?
Talking down to them.
Talking down to them. Okay. What else? Anyone want to add? Take one more. What is student?
Not treating them with respect.
Not treating them with respect. Yeah. So anyone else? Before we go to the definition.
Maybe like any derogatory statements made towards someone.
Derogatory statements. Mm-hmm. Anyone else? We have a bunch of people we haven't heard from.
It could be even just ignoring them.
It could be what? I'm sorry, there was an echo.
Ignoring a student, not giving them time. Yeah.
Yeah. Any other ideas? Got a good list of things here.
Belittling their question.
Belittling their question. Mm-hmm. Any other ideas? Okay, good. All fit into the category of student mistreatment. So the official definition is here. Policies feature actions or behaviors that treat a learner in a threatening, intimidating, or otherwise inappropriate manner sufficient to adversely affect the learning environment. So anything that can be threatening, intimidating, inappropriate is classified as student mistreatment. So we really want to be careful, and sometimes we don't realize what is associated with it, because it is broad and there's a lot of things that can go under that. So we really want to be careful. What are we saying to students? How are we behaving? And that's so they don't interpret it. Sometimes it could be misinterpreted, or sometimes it really is mistreatment. So we want to be careful, and we want to be careful about our own state of mind. And sometimes we're having a bad day, and not to take it out on students, even if we don't realize, because that can be considered student mistreatment. So what happens and by whom? So as we said in the video, the student probably didn't feel too good about himself. He might have felt belittled, and that's where scut work comes into play. So if you're giving students scut work that work with no educational value, saying, "Hey, get my coffee every morning. Would you? Do you mind doing that?" They could feel belittled. They probably are going to feel as if you think lower of them. And who does it? It's not just attendings. It can be residents, nurses, peers, patients, anyone really can be mistreating students. And sometimes there is that cognitive bias, right? Sometimes we think, well, that person's an attending. They know what they're doing, or we don't want to speak up. So we really want to be careful about it, because it doesn't matter what your role is. Anyone can be mistreating and belittling people. So we want to escalate it and identify it. And there's consequences. It causes a lot of stress for students. It's hard enough for a student balancing work and the rest of their life, family life. Student burnout comes into play. There's physician suicide. That's a hot topic. Does it happen often? No, it's not happening every day, but it does happen. And so we want to be aware and prevent it. And you can't have a positive learning environment if it's going to be hostile. So, there are a lot of consequences, and it leads to depression, anxiety, decrease. It affects their confidence level, can lead to substance abuse. So it can lead to a whole array of issues, either at the moment or even down the road. Next slide. So what do students want? They want to feel included. They want you to know their name. They want to feel a part of something. They want to feel a part of a bigger picture. And they want to do things. They want to play an active role. They want to learn, and they want expectations. They want to know what's expected of them, because otherwise they're coming in blindly, and you want to be organized. And if they feel that they know the expectations, they're going to feel more confident and more comfortable with you being in the classroom, being with patients. So remember, you're always on as a faculty member, and I think role modeling is the most important thing you can do. They're always watching. Students are always watching their teachers, and the chiefs are going to do what the attendings do. The residents will follow the chiefs, and the students will follow the residents. So just to keep in mind that everyone's always, we're all being watched, and we're all role models to some extent. So this is our medical student code of conduct, and it's in our student manual. And I wanted to put this up because There is a connection to what we're talking about today to the policies of our school. So we instill this in the students from day one, and it's important to have those reminders that we don't tolerate mistreatments, and it's important to have that professionalism and mutual respect, and it's expected not just from students but from everyone, professors, supervisors, no matter what your role. We want to have that culture of mutual respect. And when we do see an issue, what do? We've just been talking about the importance of escalating and reporting it, but who can we go to for help? So the clerkship program director, I would say, would be on the hierarchy, would be the person to report issues to. And then after that, we have Dr. Lori Sullivan, who's the Associate Dean in the Office of Student Affairs and Wellbeing, and her contact information is there, her email and her cell phone, and she's happy for you to take her information down, as you should, if there's any issues. But when things do come up, the clerkship program director should be aware and should be notified. So those are two really important resources for you to have going forward. Any questions on safe learning environments, student mistreatments? Any questions about what we just discussed in the slides? Anything we want to add that I didn't mention that you think is really important to this topic?
Actually, Jennifer, I'm curious because again, I think the educational culture has changed dramatically over the past few years, and my sense, certainly when I'm watching, although it may just be the Hawthorne effect, when I'm watching, I see very little evidence of, quite frankly, overt maltreatment of students in the environment. I'm curious, in the faculty that's here, do you think this is still an active issue in the clinical environments that you're working in?
No. But I've seen things come. I've been in medicine 30 years, so I've seen the dramatic changes. So it really seems great right now compared to what it was like.
I'm sorry, who's speaking? I can't.
This is Aditi.
Oh, hi, Aditi. I'm sorry, I didn't see you there.
So yeah, the change is dramatic. You talk about being in medical school 25, 30 years ago, things were terrible. They were terrible for women in general, but just terrible for men, so it was a very different world. So things are really, really much better than it was before. Could we improve? Probably, but I don't think it's that big of a problem as it was, unless you're seeing something different. That's just my take.
I would agree with Aditi. I really don't see that much, at least not on the medical type services where we are.
This is Lauren Guth. Can you hear me?
Yes, we can.
Okay, good. I don't see it at family medicine at all, but when I interview applicants, I ask them about a time when they had a stressful event and how they coped with it. And a lot of times people will share, belittling and things like that from other attendings that they've experienced in medical school. So I think it still happens.
Yeah, I think you're absolutely right. I think that there's probably specialty differences in its frequency and probably institutional differences. My daughter was a medical student at Hopkins and is now a resident there in surgery. And the stories that she tells me, it still amazes me that kind of behavior exists. So I think you're absolutely right. I think it's probably site specific, maybe to some degree specialty specific, but certainly dramatically better than when I was in medical school. And quite frankly, it was pretty routine to be belittled by attendings. And I don't see that happening very often anymore.
Have there been many complaints from our School of Medicine students?
No.
I was just going to say, at least as family medicine clerkship director, thankfully I haven't received any medical student complaints. And I make it a point, and I know that all the clerkship directors do, an orientation for every block. We do have a slide or two about mistreatment, and we tell them definitely come to me. I am the point person. They also have anonymous, they can go into a website, it's a school website, and they can anonymously report any mistreatment as well. But I haven't heard anything for my clerkship, so I'm hoping that means that if it's there, it's minor. But again, so far I haven't heard anything, and I hope it continues to be that way.
Well, that's partly why this is the first set of issues, is that we want to be anticipatory, obviously, and indeed, and hopefully head it off at the pass before it even becomes an issue of any kind. Jen, we're going to run over if we don't get to our breakout. I'm sorry.
Yes, let's get to our breakout rooms. So I believe they're going to be assigned. So before we do that, I want to pose the question, and I believe, we said 8 to 10 minutes, but we can make it a little shorter if we're running over.
Make it 5.
Okay, 5. Okay, so I want everybody to think about, put yourself in the shoes. If you were a junior attending and your senior attending was being abusive towards you, okay, they were belittling you, they were making you do scut work, okay, a number of things could be going on, but you really felt that it was abuse. What would you do? Okay, and we're gonna discuss it with our group, and then we are going to debrief. Okay.
Hopefully everyone had an opportunity to sort of explore how they would feel. And the exercise's purpose was to put you in those shoes. Obviously, imagine how the students must feel. But with no further ado, I'd like to introduce Doug Fabrizio, also one of our faculty development trainers, and has been very involved in developing a lot of this material as well. Doug, take it away.
Hello, everyone. Thanks again for rejoining. So we're going to talk about the 1 Minute Learner now. And just for a time check, it's 7:05 right now. I'll try to finish this up around 7:15, 7:20, so we can have a brief discussion and get to a few other things. Okay, so the 1 Minute Learner, it's a really great model for structuring clinical interactions and the conversations around expectations and goals with your students in clerkship. And so we're going to get into the models, but just before we do, some of the learning objectives. Really, the goals are so that you can elaborate on the importance of the expectations and the goals of both you and the student. That's what we're really talking about here, and how we can facilitate a conversation around that so that everybody's on the same page to optimize the experience. Ideally, you want to be able to encourage self-directed learning, goal setting, and self-analysis on the student's behalf. And then really the ultimate goal would be to actually utilize the 1 Minute Learner to kind of enhance those targeted clinical communications that occur with your clerkship students. So the 1 Minute Learner, it's actually developed by Miriam Hoffman, who's here at the Hackensack School of Medicine. And it's a structured model all around the conversation regarding expectations and goals of the students and of yourself during the clerkship experience. So in terms of setting expectations, really the question is, well, why do we do this, and how does it benefit both the student and yourself? Now for the learner, the process of setting expectations, and by setting expectations, we mean things like letting them know how the day is going to unfold. It can be very administrative things, such as like the time they should get there, what they should wear, but also, the kind of patients they're going to see, and all of the components of a day. The process of doing that helps them clarify their role. It gives them a very beneficial sense of structure, which hopefully helps alleviate a lot of the anxiety and the unknown that can be associated with these students who are still relatively new to the clinical environment. So it allows them to have that other stuff processed and mapped out so they know what's going to happen. And the ultimate goal would be that now they can really focus in and use most of that mental effort on treating patients and learning from yourself. Now, from your perspective, the process of setting expectations can really help the student hit the ground running. It can make your life a little bit easier and more efficient, really can kind of eliminate some of the questions and the administrative concerns that might occur if you didn't take the time to have that conversation. And then at the bottom, you'll see highlighted, the learner and yourself, you'll get on the same page in terms of what the expectations are. Now, the same can be said for setting goals. So the process of setting goals for the student or the learner, it facilitates self-directed learning, which is really an overriding principle that we have throughout the School of Medicine. We want these students to be advocating for themselves and really guiding the process. Taking the time to discuss goals can increase rapport that you're building with a student, even if it's on the first visit. It's a great place to start a conversation, get to know where a student has been and what their goals are and how they feel they're prepared. The student, again, having the chance to discuss their own goals, it'll increase their own self-motivation and it'll show that you care about their academic journey. So it's a great place to start the conversation. And then for you as the instructor, it gives you an idea of where the student's been so that you can kind of start to think about some different learning experiences that you might like to provide them that are customized based on what the student has seen to this point. And again, it gets you and the learner on the same page. So these two components really can kind of set the stage for a great clinical experience. Now, the model itself is a 7-step model, and we're going to get to it in the subsequent slides. Before we do, though, there's what we call a huddle. And the best practice with regard to the huddle and the 1-minute learner would be to have a conversation with the student in some format. It could be a phone call or an email or something. In a perfect world, you're talking to them even before they come to the clinic. And the reason that you do this is because it kind of gets the student to start to think about what their own goals and expectations are of the upcoming clerkship experience. A little bit of self-analysis in terms of what they've seen, what they feel strong about, what they feel like they might need some room for improvement, and also gives them a chance to think about their goals. There's going to be structured goals and they're going to have their own goals as well. And then in consideration of what you hear from the student, it gives you a chance to think about your own practice and maybe keep in mind some patients that you might want them to see or not see. And it just gives you, again, you kind of starting to get to know the student before they even come in. So the huddle is the best practice. If you can make it work, it's a great way to begin. Now we'll jump into the 1-minute learner, the model itself. So on the left, you'll see the 7 steps. We're going to highlight which one is active, and then we'll just go through a couple of key components associated with each one. So in the first step of the 1-minute learner, we're really talking about goals here. And the purpose is to understand what the student has seen to this point. There's a variety of settings that they may have been in. You know, they've done LCP1, they've done LCP2, they may have had other clinical experiences, but even that can vary. You know, it could be at one specialty or another. So it's important to know what the student has seen to this point, and it's equally important to know what their goals are. So they have their own short and long-term goals. They also have the goals associated with the clerkship, which are more structured and kind of not up to them necessarily. And then they have their growth goals, which are kind of SMART goals that really should be very structured and have specific markers around how they've been achieved. And it's important to get a sense of where the student is with all of this stuff. Now, from your perspective, it's also important for you to share what you would like the student to get out of it. So you give your own short and long-term goals. And again, this is a great overarching way to start the conversation. So once you've talked about goals, it's time to move into step 2, which is a little bit more granular. So now we're going to start to map out the way that the day is going to work. And so we might want to ask the question of when and how is the student going to start seeing patients? Based on the conversation about goals and their past history, you can decide if they're going to see just any patient that happens to come to your clinic on that day, or if you want them to see specific patients with specific diagnoses that are more or less complex as you see fit. Other considerations can be if the student's going to do admissions, or if they're going to see patients alone or with you. Now, to kind of speak more about that last bullet in particular, we'll jump into the next step. So step 3, which is how much and how long. And so now we're really talking about the actual visit with the patient itself. And so how much of that visit should the student do on their own? For example, do you know this patient and are you going to do the introduction before the student sits down and kind of talks to them? Or would you like to see the student's entire process and see how they do it themselves? The next bullet is particularly relevant because we've actually seen in a lot of conversations with preceptors for LCP1 and LCP2, one of the understandable yet kind of funny / frustrating things is that a lot of times they'll say their students are getting fantastic histories, but they're taking 20 minutes because they're sitting down and the student is giving, or the patient is giving them their life story. And so it's great, they're getting a ton of detail, but it's obviously not efficient. And so something like as simple as having a conversation with the student to say, hey, I would like you to spend 5 or 10 minutes doing this portion of the session with them can really give the student some framework to manage their expectations and to also work on their communication skills. You know, sometimes it can actually be hard to get the patient to move on to a particular subject. So giving the student a framework can help them work on those different elements of patient care. You also want to consider what the student should do when they're done seeing the patient. Again, practical considerations about the patient visit itself. So step number 4 is presenting. So again, so after the student has seen the patient, now we're going to talk about the way in which they present that material, whether it be to the student or to the patient, to yourself, or both. And so where and how should the presentation occur? Should it be in the patient's room with the patient, or should it be separate with you in the office or walking to the next patient? Should there be a format? Would you like the student to write something up, or is a verbal conversation sufficient? What level of detail are you looking for? This is a skill that students can learn, to be concise while also providing sufficient information to show you their clinical reasoning. So having a conversation with the student to say, I would like you to spend 10 minutes presenting, I'm looking for a verbal format. And these sort of things can really give the student a great framework to work from. Now, highlighted here is a very challenging one, and that's we recommend scheduling time. This would be in a perfect world, but we totally understand that many times the schedule just won't allow that, or things will change. So totally understand that. Ultimately, what we would ask is that you have a conversation with the student, and that lets them know that they are going to have the chance to present in some form. Even if it changes, the simple act of acknowledging the presentation component and working to make it happen can be very reassuring for the student. Now, to take a quick sidestep, we have additional models that assist with the presenting step itself. And so, not to make things too confusing, but I'm just briefly going to show what we call the 1-minute preceptor and the SNAPS model. So let's say you were in a clinical situation and your student had just seen a patient, but they were struggling to provide you with a good analysis of what happened. Maybe they were just stuck and they didn't really know where to go, and they just needed some framing. You can use these models to kind of help structure that. So the 1-minute preceptor is a preceptor-led model in which you would essentially go through the steps that are shown here. So asking the patient or the student what they think is going on, what led them to think that, giving them some general information that's your own clinical expertise, reinforcing what they did correctly, and then correcting their mistakes. So this is great if your student comes out of that patient room and they're just really not sure where to go. It's a lot of information. It's very useful. And we also, just so that you know, the presentation here, if you were to click this link, we've done separate presentations that go into in depth on the 1-minute preceptor and the SNAPS model. And so the link points to a video that will show that. So you can do some additional learning there if you would like to, and we'll share this presentation. Very, very briefly, the SNAPS model is a more aspirational model. This would be a little bit more student directed. So the student would be kind of coming out of that patient room, summarizing what they saw. A key differential here is that they're going to be providing, they're going to be narrowing the possible diagnoses to a few different things, and then they're going to be comparing and contrasting. So their clinical reasoning is getting a little bit higher level here. They're going to be proactively asking you questions. They're going to be coming up with a plan, and then they're going to be doing some further learning. So again, these are just 2 different ways of actually presenting the clinical information, and you can get more information by clicking on the links off to the side. Now, jumping back to the 1-minute learner, so charting would be the next step. So again, it's good to have a conversation about the setting in which the student will write the notes. I believe we use Epic at Hackensack, so just a conversation saying they're going to be documenting at this station at this time, and maybe you want to sit next to them while they do it. But whatever the mechanics are around the charting aspect of the day, it's ideal to have a conversation about where that will occur. Again, with the goal of the student kind of can then compartmentalize that information, just focus on patient care. Questions, and so this is another important step. So if the student has questions, which we hope they do during the course of their clerkship visits, how should they ask them? Should they ask them right as they come up? Should they be documenting them and talking about it with you at the end of the day? Again, just have that conversation so that everybody's on the same page. And then feedback. feedback is a critical one that relates directly back to step number one, which are the goals. And so as it relates to feedback, you want to talk to the student about when and how will you give the student feedback? Will it occur, while they're in the room, at the end of the day, at the end of the program? Now, feedback should always relate directly to the goals that you identified. So in the beginning of the day, you talked about your goals and the student's goals. When you visit the feedback component of the day, you would ideally want to say, okay, we said this morning that we were going to work on X, Y, and Z. How do you think you did? And one of the main objectives here is to get the student to really be self-reflective. We're going to talk about it in subsequent slides, and actually the session number 2 of these trainings focuses directly on what we call the Forward with Feedback model. And that's a model that we've created specifically around the feedback conversation to help guide the process and really make it straightforward. For now, the main thing to know is that feedback and goals are intimately related. So as you work with the student to have them develop their own feedback and performance, that would then feed the goals that are used for the subsequent session. And so this kind of all is very cyclical. Now, just some summary points about the 1 Minute Learner. It's not a prescriptive model. The idea is to get you thinking about these different subjects so that your clinical visits are more effective. Now, in some situations, you're going to want to use all of the steps. For example, a student on their first visit, it would be great to actually go through all of the steps so that they understood all of those administrative elements and how the day was going to run so that they could then focus on patient care. If you had developed a relationship with the patient and they were here for their third or fourth visit at the same clinic with you as their instructor, it's very likely that you would only want to focus on the goals and the feedback, for example, because they already know how those other elements work. And then lastly, as I mentioned, the 1 Minute Learner works hand in hand with the Forward with Feedback model, which we're going to get into in part 2 of this training series. So more to come on that for sure. Very quickly, there has been research done on the 1 Minute Learner and its effects. So this is actually done by Dr. Hoffman and her colleague. And what they did is they took 2 cohorts at the end of the clerkship program. First year, there was no usage of the 1 Minute Learner. And then the second year, they implemented the 1 Minute Learner, and they taught both the students and the instrucors how to utilize it and how to incorporate it. And you can see the difference. So for the question of I was oriented to my responsibilities and role, dramatic increase from 47% to 82%. And then expectations of my role were communicated to me clearly, jumped from 66% to 89%. So it's pretty striking difference in terms of the students' feelings, in terms of how their experience went. And we can see that this is just extremely beneficial because the less they have to question their responsibilities, roles, and the communication, the more they can focus on really the goals of the clerkship program, which is, gaining experience, working with patients, and learning from you. Let's see what time we have here. So we're running a little late on time, so you can read these later, but basically these are just a couple of vignettes that talk about the student's perspective and kind of give you an insight into how they might feel a little bit scattered coming into a new day at a clinic. And then the second one is really how you might feel. So sometimes you might be really busy and you're coming in and you forgot you had a student, and just thinking about the state of mind you might be in that situation, and then overlaying that on the 1 Minute Learner and how that can then really frame the day. So you can kind of block out 5 or 10 minutes at the beginning of the day to just talk about those elements and then have a nice efficient day afterwards. So those are just some things that you can kind of read later. I want to jump in though to, we had another breakout session, just a brief activity for you to think about. And that is, so what I would like you to do is I would like you to, for anybody that's had clinical teaching experience in the past, I would like you to verbalize your recollection of the first visit from a patient that you had in the past. I want you to think about how it went. And maybe if you can, now that you've seen the 1 Minute Learner, did you utilize any of those steps without realizing necessarily what those steps were? So we want to start to overlay kind of what we've experienced in the past with the 1 Minute Learner model. And then as a group, I would like you to just try to brainstorm ways that you think it might be realistic to incorporate this model in your practice. I know there's a lot going on, but let's talk briefly about some ideas that we might have. So that's what I would like us to do. And maybe we can just do this for 3 to 4 minutes.
Doug,
Yeah.
I probably, just in terms of time, why don't we just stay together as a group and just have this conversation as one group? Because it's already quite late, and to wrap up, I think it might be better if we just stayed together as a group and had this conversation.
Sounds great. So does anybody have any ideas in terms of how they might consider rolling this out in their own practice in consideration of every other thing that you have going on and how busy you already are? Do you see practical ways that this could be utilized?
I think, it's hard enough to be able to see 10 or 15 patients, 10 patients, and then, have a student. So it is good to have this structure, but it often doesn't, you miss one or you miss two. The aim is that, you hit as many as you can in that structured model, and sometimes you don't, just because the patients are different. Somebody comes in with an acute problem,
Right.
is a totally different kind of visit. And if somebody comes in for, say, their routine chronic disease management, it's a totally different kind of visit. So the visits differ. So the huddle is wonderful, talking to them before, giving the student a little bit of a history of what the patient is coming in for, because the patient and what you expect of them, and giving them the time that I want. I always believe in telling them that I want you to take a 5-minute history, or okay, this patient is coming in after 6 months, she has a lot of issues, so you can take, say, 10 or 15 minutes in a history and then come and present. So but being so scripted all the time doesn't work.
Totally.
It varies as patients vary or our time varies.
Now, it sounds like you're actually using quite a few elements of the 1 Minute Learner already, which I think is wonderful. And really, I guess the overarching point that I would try to make is that we don't want to create extra work. It's not a matter of having to go through every step. What we want is to kind of give you just a framework to have in the back of your mind for that conversation that you're having with your student. It can even be as you're walking from the front office to your office, getting ready for the day. But if you have in your mind, okay, I really want to understand what the student's goals are. I want to make sure I tell them how many patients they're going to see. I want them to know that they're going to have the chance to present, and then that they're definitely going to be able to get feedback. Like, just going through that extremely quickly can give the student such a sense of calm and structure for their day that I think as you practice with it, I think you'll see like the student performance actually increase, and they'll likely be less anxious, and they'll probably ask less questions because they'll have more of an idea of what to expect. And so the goal is really, it's to help both the student, but also you as the instructor. If we can kind of figure out creative and kind of efficient ways to cover those topic areas, it should make your life easier. And especially if you have multiple students, they'll all kind of know where they stand and they'll know what's expected of them. The other thing that I would say is we have included what we call like a pocket card of the 1 Minute Learner in the meeting invite. And so you have that as an attachment. That just has the 7 steps in like a very, very brief form. And Dr. Giuliano is actually holding it up. And again, in no way do you need to go through word for word those 7 steps, but it sounds like you're already doing quite a few of them. So just taking a look at the model and familiarizing yourself with the general categories can really go a long way in just adding little bits and pieces to the conversations you're already having. But I think you're doing a great job. It sounds awesome.
I always find something that works for me, and I think works for a lot of my colleagues, is at the end of the session, when the patients are done, you take that extra 10 or 15 minutes and sit with the student and find out what went well, what did not go well, what would they like in their next session. That I think is a really rewarding thing, because then they understand, and then I understand what this particular student didn't understand or, wanted more time on. And so that that feedback both ways, them to me, me to them, I think goes a long way in making,
I think that's great.
Or of a learning event.
And it really goes a long way from the student's perspective to kind of say, okay, this instructor really cares about my learning. Like, they took the time to ask me what I thought what I would like to do moving forward. So it's great for kind of rapport building as well. And I think you'll continue to see the student performance, increase the more confident they get. So that's
I
great.
really
Thank you
like
for
doing
sharing.
that as well. And I just wanted to add that it also actually having that expectation, like Aditi said. Today, for example, I had a medical student in a very busy afternoon, and prefacing the start of the visit or the session, this is going to be very busy afternoon. There probably won't be a lot of time for questions or debriefing after every patient, but at the end of the session, we can go over everything. I think setting that expectation not only reduces the student anxiety, but also even our own anxiety, right? And making sure that our patients get the best care, but also teaching the student.
I think that sounds really, really great. And can I ask, like, how long did that conversation with the student kind of take to have?
It really only takes, I would say, less than a minute, and they're very understanding and appreciate
Beautiful.
it.
Yeah, I think that's a great way to approach it.
I don't work with students in the same way, but I would imagine that for the provider, when you're engaging the student with this technique, that it can probably make it a lot more fun and engaging for you as well. Instead of that, oh no, I have a student, it can be like, okay, we can work together and, team up. So
Absolutely. I think that's a really good point too. It's funny because in the vignette, it actually says, oh no, when the preceptor kind of forgets they have the student. And so
I read that, but it's true.
if nothing else, it can be nice in that situation to fall back on a model. If you don't even realize that the student's going to be there and they kind of just show up and you're scrambling, you might want to just go back and say, okay, what are the steps? And if you follow them, you can really have a nice clinical day, even without much preparation. So it's nice to have in that sense too. I will just share my screen briefly. So thank you all for participating. And I just want to show a couple of other things. So that's the 1 Minute Learner. You can reach out to us for more questions or practice with that anytime you would like. Also, just so you know, in this PowerPoint deck, we have some resources. And so we have the STFM website is actually where some of the original 1 Minute Learner materials are. The Teaching Physician website is a paid website that we've paid for, and you can actually use the username and login information provided below. We've highlighted the main sections that we have found interesting and helpful, but you can go anywhere. We have a faculty development YouTube page that has some of the more detailed conversations around the other things that we've mentioned. We also have an event calendar that's new, but it's going to be showing how you can register for session 2 of this series of learning, as well as everything going forward. So you can save that and bookmark it. And then just very clearly, so the second session will be offered October 28th at Mountainside and December 8th at Jersey Shore University. And you can get the specific registration and sign up stuff on our events calendar. So please feel free to click over there. And then Dr. G.
Yeah, and those last dates that we just gave, the physical location for a live aspect of it will be in those sites, but they'll all be on Zoom, so you can join us. It doesn't matter where you are physically. So they'll be both live in the locations, but also Zoomed. And of course, as I mentioned, this is recorded, and we'll eventually put this up on our website as well, so you can review this a little bit later, which I think will be useful. I just wanted to end by thanking everyone for taking the time. This is, I know, it's a little late in the evening, and it's wonderful that everyone was able to stay for most of the time. And also recognize that, this program really runs parallel to an extensive program, which is actually being developed as we speak by family medicine, by neurology, and by other subspecialties, not just at JFK, but across the system, where residents will be schooled in exactly the same models that we've just talked about. And actually the development material is almost identical. So recognize that this is a process that's happening for students, for residents, and for faculty. And if you ever see a rattle session that's going on in your family medicine department and there's enough space left or it's being Zoomed, I probably would encourage you to try to join that as well. We've already gone over by a little bit. I want to thank everyone again. Rosa, thank you for getting this organized. Dr. Winter, thank you for the invitation, for bringing us together. And I'm looking forward to working with everyone and seeing you live in the relatively near future.